This is Marcy Nielsen. I am the CEO at the Patient-Centered Primary Care Collaborative, and I'd like to welcome you to our national briefing webinar. The topic for today and the title of our webinar is From Regulation and Documentation to Transformation, the Plantree Framework for Patient-Centered Excellence. We are celebrating National Primary Care Week and Patient-Centered Care Awareness Month, the month of October, and so we are thrilled to have Plantree with us, and we can learn more about their very inspirational program that, if you can believe it, is about accreditation, but even more so about transformation. I'm going to just go over a few housekeeping items, and then I will introduce our presenter. So first, wanting to make certain that everybody is aware that we've extended early bird registration for our annual fall conference to this Thursday. So please do go to our website. We'd love to have you join us at our conference, Investing in Primary Care, Patients, Professionals, and Payment. Terrific opportunity to participate in literally dozens of panel discussions and have the opportunity for some in-person networking with both our panelists as well as attendees. We will be learning more at that conference about the exciting news we announced last week regarding a major transformation effort by the federal government to help small and medium-sized practices transform to become patient-centered medical homes, advanced primary care, whatever title you want to put on the concept. That news came out through the Transforming Clinical Practice Initiative, and our conference is, I think, going to provide the perfect opportunity to get all those folks who are going to be involved in the TCPI together, and we'll be talking about how anyone interested in this important over the course of the next 4 years can get involved. So please do join us at our conference and learn more about TCPI. As many of you may know, the PCPCC was a recipient of a SAN grant, the Support Action Network, and our partners on that grant are, in fact, Plantree. So don't miss the event and the opportunity to learn more about this really critical work. In terms of the general housekeeping for this webinar, like all of our webinars, we ask you to use the software to ask questions or provide comments. And in order to do that, if you look at your screen, you can submit your questions or comments in writing using the drop-down question box that you'll see on the right-hand side of your screen. Then during the last 15 minutes after Sarah's presented, we're going to open up for Q&A that the PCPCC team will facilitate. As many of you know, we make all of our webinars available for free, and we post it on our website in the next 24 hours. So with that, it is my pleasure to introduce our speaker today, Sarah Costello. To save time, I'm just going to point to a few key items from her bio, but her longer, more detailed bio is available on our website. Sarah is a great friend to the PCPCC at Plantree. She's the Director of Knowledge Management, and she's developed a range of educational and implementation resources to help guide organizations in their endeavors to deliver patient-centered care. So she oversees the Patient-Centered Hospital Designation Program that they have been doing for some time, and she'll be sharing with us some information about that program. But also, she manages the associated Patient-Centered Merit Recognition Program, and that's the only program to recognize excellence in patient and resident-centered care across the continuum. I would just throw out that our good friends at SETMA, Larry Hawley, love the work that Plantree does, and Larry, his practice at SETMA has gone through all of the national accreditation programs and really highlights the patient-centered focus of Plantree. Drawing on the experience of healthcare organizations that implement the Plantree model of care, Sarah has authored numerous white papers on integrating the patient and family voice into hospital operations and advancing person-centered care across the continuum of care. So Sarah is the person who manages the program. She's a person who writes the research about what they've learned, and today she is going to be the person who is sharing that important information with us. Sarah, thanks so much for being here, and we look forward to, at the end of your presentation, hearing from all the folks who have checked in what their questions and comments are. So we'll spend about the last 15 minutes dialoguing a bit with them.
Thank you so much, Marcy. It's really a pleasure to be here, and I just want to thank the PCPCC for the opportunity to share with you today Plantree's approach for designing and sustaining a patient-centered healthcare culture. And what better time to do this than during the intersection of National Primary Care Week and Patient-Centered Care Awareness Month. It really is fantastic timing. This is the 9th year that Plantree has coordinated Patient-Centered Care Awareness Month, and we do encourage all of you to join us in celebrating the momentum that continues to build around person-centered care, and to use the tools and the resources that we've made available to promote courageous engagement in healthcare as part of this year's campaign. Now, having said that, I know at Plantree and at PCPCC, and I'm sure at many of your organizations as well, we're working to advance patient-centered approaches to care every month, every day, year in and year out. But there really is something about a campaign like Patient-Centered Care Awareness Month, which helps to fuel the movement and helps to fuel greater collective action among patients and family members, among the provider community, and at the system level as well. So I do encourage you to go to the URL that you see here on the screen and download the Patient-Centered Care Awareness Month Toolkit. All the materials are free, and they're out in the public domain for you to use and to put into action. The theme of this year's campaign is Healthcare's Brave New World, Patient-Centered Care. And it's one of those things where I don't think it's often mentioned as one of the key attributes of a patient-centered organization or a patient-centered interaction. But bravery really is an important part of the formula. It takes courage to thwart business as usual. It takes courage to be vulnerable and to speak up, especially as a patient if you feel it may not be your place to do so. So the photos you see up on the screen are of patients or family members, and they're all members of Plantree's Patient and Family Partnership Council. And that's the group of patients and family members that we routinely turn to ensure that our work and our priorities remain grounded in the voices and experiences of patients. And I say remain grounded in the voices of patients because that's where Plantree originated. Almost 40 years ago, so well before the terms patient-centered care or patient and family engagement or patient-centered medical home had hit the mainstream. And we are an organization that was founded by a patient, in fact, by this patient. This is Angelica Tiriot, and she founded Plantree on the premise of what would it look like to design the healthcare system to work optimally from the perspective and the point of view of patients. And her only experience in healthcare was as a patient and as a family member of some patients. But based on those experiences, she was highly motivated to conceive of a new approach to delivering care that would essentially restore the humanity back to the healthcare experience. So it's not surprising, given what I've just shared with you about our origins, that the Plantree model really prioritizes patients being respected, that they be informed and involved in care decisions and treatment planning and in the management of their own health and wellness. So if you want to talk about the power of patient engagement and the potential for patients to chart the future for healthcare, the Plantree story in and of itself is a really great example and case study, because from those humble beginnings of one patient, today Plantree is a not-for-profit patient-centered care advocacy, coaching, and education organization, and we are At present, in more than 700 healthcare sites across the full continuum of care, and from that one patient's vision, we're now impacting more than 9 million lives by demonstrating that patient-centered care really is a viable strategy for improving quality of care and enhancing the patient experience as well as the experience of staff. We've operationalized the model now in 17 different countries. So that just goes to show that there are certain basic principles for what makes quality care that really are universal: kindness, dignity, respect, feeling heard, having access to information so that you can understand and make decisions about your care, and having your preferences understood and accommodated. In so many ways, these feel very fundamental and very basic, but all of you know when it comes to really operationalizing that, that's when it becomes complicated, because when it comes to patient-centered care, essentially what we're striving to achieve is systematic personalization. And those two things may seem to be at odds, but we're looking for reliable systems and processes that enable us to identify and accommodate the needs and preferences of each individual patient, and then of course their support network as well. So Planetree's formula for doing that is up at the top of the slide here, and it relies on 4 main pillars: leadership development, staff engagement, patient activation, and performance improvement. And I'll say a little bit more about each of those. For leadership development, we really do approach this work as both bottom-up and top-down. But leadership engagement is pivotal, and that's because patient-centered care is not an isolated initiative that happens in sort of a corner of an organization or a practice. It's not something you do. It's more, it's not part of a checklist. It's really woven into the fabric of how care is provided and how decisions are made and how priorities are set. And that starts with leaders setting the tone that this is the way moving forward, and then role modeling that to be the case. And so you see here the types of support we provide to organizations around these different pillars. So we talked about top-down, which bottom-up. I mean, contrary to what the term may suggest, patient-centered care is not just about the patient. Patient engagement, co-design, partnership, all of these require the involvement and the engagement of staff. And so the Plantree approach is acutely focused on the staff experience as well. Reconnecting staff with the reasons they chose a healthcare profession in the first place, tapping into their passions, and really engaging all staff members in inclusive processes for bringing patient-centered care to life in every corner of the organization. So part of staff engagement is really developing structures that promote inclusive decision-making and raise all staff up as caregivers with the ability and the responsibility to embody the values of patient-centered care. And finally, ensuring that staff are feeling cared for and supported and nurtured in this work so that they can in turn provide compassionate, empathetic care for patients, because it's not fair of us for us to ask of staff to give what they just don't have. So we really do emphasize strongly that staff side of the patient-centered care equation. And that brings us to the ways that Plantree supports organizations in implementing practices at the point of care, with the aim really of reversing a level of passivity that's been perpetuated among patients and families really from generations of operating in a provider-centric system. This is what we mean by patient activation. It's supporting patients and families and taking a much more active, a much more participatory role as a member of their own healthcare team through patient-preferred practices that promote transparency and partnership and inclusion. And finally, we look at processes and more specifically, a culture of continuous improvement that draws on the voices and the experiences of patients and family members, as well as the staff who work most closely with them, to create efficiencies that maximize patient engagement opportunities and maximize an organization's ability to focus on the most high leverage change opportunities. So this is probably a good space to just pause for a moment and take this out of the realm of the conceptual and the theoretical and into some more practical applications of the Plantree approach, which is what you see here. And it's things like co-creating with patients and family members patient-centered tools and trainings like the patient preferences passport. And that's a tool for documenting patients' preferences to share with the care team. Or compassionate interactions training, which is designed to go beyond scripting to really build providers' comfort and confidence in meeting patients' desires for connection and compassion in their healthcare interactions. Staff retreats are a hallmark of the Plantree approach, and they really do take staff training to a whole new level. They're interactive, they're reflective, they're experiential, and they're designed to promote a unified goal among the entire team, everyone. Clinical and non-clinical, leadership and non-supervisory, frontline. And that unified goal is exceptional patient-centered care. And not as a buzzword, but as a goal that feels really meaningful and that they're able to connect to on a personal level, but also as a goal that feels attainable, that they understand what we're working toward. So I just sort of went through a menu of services and tools and techniques, but we all know that patient-centered care is more than that kind of a menu. It really is a culture that's cultivated over time through skill building and training, through efforts to harness the patient and staff voice, and finally through the development of infrastructures and practices that advance engagement and inclusion. And the Patient-Centered Designation Program that Marcy referenced in her introduction of me is Plantree's evaluative framework for patient-centered excellence. And it pulls all those elements together into one cohesive framework for designing and operationalizing patient-centered care to drive deep-rooted and sustainable transformation. The program's organized around more than 60 criteria. I've just pulled out a few examples here. And it's across 11 different dimensions of patient-centered care. And through the criteria, the designation framework offers up a more concrete destination or a definition of what excellence looks like. And that's how it really accelerates organizations' efforts, by helping them to focus in on the most powerful levers for change, and hopefully helping to minimize the distractions of some of those non-value added activities. So as you can see, the scope and the depth of the criteria focuses on patient and family co-design at the organizational level, but it also focuses on family engagement and patient engagement at the point of care, but also staff training, and again, the intersections of patient-centered care and quality and safety, and creating better quality transitions. So again, this is just sort of a snapshot of a few of the criteria. Collectively, the criteria complement other traditional quality recognitions and accreditations by really traversing a broad spectrum of aspects of the patient experience, the family experience, the staff experience, the physical environment of care, collaboration across the continuum, and then work out in the community as well. These 11 dimensions of patient-centered care that you see here really harken back to Plantree's historical methodology, which is based on 10 components that reflect what patients have reported to us in focus groups and other research we've done are important to them about their healthcare experiences. And then within each of these 11 dimensions, there are the specific criteria. Some focus on infrastructures to support sustainability. Others are more specific to practices, though the emphasis is largely on the desired outcome versus a highly directive mandate for how to achieve that outcome. We want to make sure there's ample room for flexibility there. And then finally, there are some criteria that focus on specific elements critical to culture, like leadership practices and how data is used to drive change. And as you see here, the program's been endorsed by the Joint Commission as a merit badge on its Quality Check website. So what makes this program distinct? First, I did want to establish that it is recognized to, it's designed to recognize, I should say, superior performance related to patient-centered care. And there's a difference between establishing minimum standards and continuing to raise the bar. And both certainly have their place in driving quality in our healthcare system. But it's our vision, of course, that patient-centered care will indeed become the norm and the expectation for healthcare around the world, but we need to be honest that we're not there yet. And this program honors those organizations that are ahead of the curve and holds them out as exemplars for what can be accomplished. But there's nothing that adds more credibility to the program and to the criteria and to the evaluative process for the designation program than the role that patients have played and continue to play in defining and assessing patient-centered excellence. Patients have informed the criteria themselves, and when we make changes to the criteria, we routinely go back to patients for their involvement in developing those changes. Patients are involved in site-based evaluations, so they validate that their lived experiences are consistent with what the organization has self-reported in the application, in the written documentation. And patients also serve on the independent review committee that ultimately confers all designation decisions. I mean, I don't think that we could, in good faith, offer a patient-centered designation if we didn't practice what we preach about co-creation and partnership with patients. So we're really proud of the involvement of patients since the very beginning of this designation program. The criteria also heavily emphasize the undisputable fact that the only way to deliver on the promise of patient-centered care for patients is to address the staff experience. And we've already talked about that, but really taking action to reconnect caregivers to the deeper sense of purpose of their work and equipping them with the tools and the support they need to deliver compassionate care, to engage patients and family members, to dissolve organizational silos, and to honor the patient voice as an expert voice that can lead us to better health care. So the staff experience is there's quite a heavy focus on the staff experience in the designation criteria, but also in the evaluation process. And finally, something else that makes the patient-centered designation program unique is that we feel that a recognition essentially around the patient experience has to be based on patients' lived experiences and to the point I just made, to the experiences of the staff, which is why ultimately designation is conferred based on observations and discussion with patients, family members, and staff. We come on site, we observe, we do focus groups with patients, recently discharged patients in hospitals, or interviews with current patients. And we use those focus groups and interviews to substantiate excellence in practice. And that's why this recognition means so much to an organization. It's awarded because their patients validated that they feel cared for, respected, heard, and partnered with. And that's really powerful stuff. And it can really sustain caregivers on the days when it may feel taxing and difficult to deliver patient-centered care excellently. And of course, the flip side of that is that because this is a recognition that's based on what we hear in focus groups, it takes more to achieve it. There needs to be quite a high degree of hardwiredness for patients to consistently report back that practices like offering to share the medical record or capturing their goals in their own words and involving family are occurring on a regular basis. So you can't really teach to this test. I mean, you really do have to do the hard work, and that's the other reason why it means so much to the organizations that achieve it. So just a couple more notes on the criteria as a whole, and then we can talk about sort of the impact that we've seen as a result of this framework. Despite the differences in care settings and healthcare delivery models and cultural expectations around healthcare in different regions of the world, we have found that the major tenets of what it means to deliver patient-centered and staff-supported care really are universal. They're not setting-specific and they're not country-specific. So that's what I mean by the criteria being integrated and universal in concept. So we don't have one set of criteria for hospitals, one set of criteria for long-term care communities, one set of criteria for primary care. It's one core set of criteria with some criteria applying to only some settings, and there being some degree of modification based on the setting. But the core set of criteria apply across the full continuum of care. Now, how the spirit and intent of each criteria is fulfilled may very well differ from setting to setting or even from country to country. And that's why we've worked really hard to develop criteria and use language that provides the direction that we know you're really hungry for, but that also leaves plenty of room for flexibility and innovation and room to accommodate the nuances of different cultures and healthcare settings. And that's because we certainly would not have made a meaningful contribution to this field if what we created was a rigid recipe for patient-centered care that didn't leave room for innovation and evolution. That's something we really want to support and celebrate. So you've heard me talk about more than 60 criteria across 11 dimensions, and we're talking about deep-rooted sustainable transformation. And that can feel like a lot. It can feel like a very big and daunting goal. It can be overwhelming. But this is intended to be a very affirming process and a process that drives success. And so to that end, for sites interested in pursuing designation but knowing they may not quite be there yet, we've built in some intermediate tiers of recognitions, bronze and silver, and they're both built around the same set of core criteria that an organization can set as shorter-term targets as they continue to work toward the gold standard. So it's basically a percentage of the criteria that need to be fulfilled for each of the intermediate levels of recognition. So to date, we've recognized 75 sites with the highest level of recognition, gold level designation. And as you'll see from the numbers here, their experiences have validated that the criteria and process really do apply across care settings and cultures. So we've designated sites so far in 4 countries. We've designated hospitals, long-term care communities, outpatient settings, including 1 primary care office in the Netherlands. We're still eager to designate our first in the United States. We've designated specialty hospitals and behavioral health settings as well. And an additional 23 sites have been honored with bronze or silver level recognition, including a number of VA medical centers, as well as most recently a hospital in Saudi Arabia. Again, just sort of demonstrating that the concepts really do apply in so many different cultures. And these sites really do serve as living laboratories for what it takes to achieve and sustain patient-centered care in action. They're also our evidence base. So we can draw on the experiences of these sites to illustrate that the framework for change does indeed drive improvement, not only in the patient experience, but also very importantly on the staff side of things. So I just pulled some data from some of the sites that we've worked with that really sort of illustrate this phenomenon of how intertwined patient satisfaction and staff satisfaction really are. So this is data from Stanford Hospital in Connecticut, and it tracks the trajectory of their staff and patient satisfaction over the time that they've been working to implement the Plantree model. And it's worth noting that in 2003, the first date year, that's the year that they began sending their staff, all of their staff, 100% of their staff, through a sort of immersive retreat process. They had an aggressive goal of getting all their staff through within a 1-year time frame, because it was really important for them that they had everybody on the same page with a common understanding around what this patient-centered care and Plantree was going to mean for the hospital, and how everyone had a role in bringing it to fruition. So as you can see, as they continued using this designation framework, they saw an increase not only in their patient satisfaction, but also in their staff satisfaction as well. And we're now doing some work with their integrated physician practice, introducing elements of the model into the primary care setting. And this case study tells a similar story, although I've also included data here in red that adds in improvement in the physician experience, and it tracks right along improvement in the patient and staff experience. So employee in blue and patient in green. This is the hospital CAPS survey, and it's from Enloe Medical Center in California. And theirs really is a great story to tell. So if you look at the green bars, this reflects their performance on the HCAP survey. And in 2008, this hospital was in the 2nd percentile nationwide. By 2013, they were ranked 12th out of all 245 hospitals in California. And so in media reports, the hospital's leadership attributed that improvement to the hospital's adoption of a patient-centered care philosophy, and specifically their pursuit of Plantree designation. And those numbers and those charts definitely provide a compelling case for the Plantree model, but they don't tell the whole story. I did want to sort of give you some additional color commentary here from those who have implemented the Plantree approach about what it really meant for them and what it did for their organizations in terms of helping them to maintain momentum and remain focused on what was most important, really helping them to integrate it into their way of delivering care and as a part of their culture, really driving continuous performance improvement, and just really also supporting them in doing the kind of work that they're really proud of and are wanting to do. And so to have these individuals attest to the fact that the process was a meaningful one that's positioned them not only for short-term success, but ultimately for long-term sustainability really does mean so much. So I'm sure you've noted that these examples have largely focused on the acute care setting. But through a pilot as part of the state of Connecticut State Innovation Model Advanced Medical Home pilot, we are now actively working with a number of primary care practices in our home state, Plantree is based in Connecticut, to create an innovative pathway to patient-centered excellence that marries the NCQA PCMH standards with the Plantree Bronze criteria. You'd expect that the PCMH standards and the Plantree Bronze criteria would overlap a fair amount, and we've crosswalked them, and in fact they do. So what we have developed is this sort of merged pathway where into this advanced medical home model where practices will receive credit, if you will, for achievement of PCMH as evidence of fulfillment of more than half, almost 60% of the required bronze criteria. So that's, that just goes to say that for practices that have been recognized as a patient-centered medical home, they're already halfway to bronze and can really focus in on those additional elements of the Plantree model that really do drive that transformation. Specifically, patient and family engagement, co-design of practice transformation, restoring kindness and compassion and human connection to healthcare interactions, and of course, support for practice staff. So this sort of identifies those areas that the Plantree bronze criteria are designed to strengthen and really emphasize through the advanced medical home pilot. And to illustrate the power of the combined pathway to patient-centered excellence, I just thought I'd share a really brief case study of a longtime Plantree member. This is Hudson River Healthcare, and Hudson River Healthcare is a network of federally qualified health centers, and they now have over 30 sites in 10 counties of New York State. And we've recently profiled them in some Plantree publications and celebrated how by really emphasizing patient engagement and staff training and patient co-design, Hudson River Healthcare has just really distinguished itself as the real deal in patient-centered care. And they represent the level of transformation we're aiming to drive through this pilot in Connecticut. And we look forward to expanding it certainly beyond the state of Connecticut as well, because we feel really strongly that this is a case of the two frameworks working together, and having these two frameworks working together in concert with each other, creating results that are greater than the sum of its parts. So we're really excited about this opportunity and excited to share that with you today. And I know we're going to open it back up to questions, but I wanted to make one final plug for Patient-Centered Care Awareness Month. Today is October 6th, so we still have something like 25 more days of the month to celebrate courageous engagement in healthcare, and I really do invite you to download the toolkit and join us in commemorating all the exciting momentum that's been building around patient-centered care.
Thank you so much, Sarah. This is Amy Gibson, the COO with the PCPCC, and I want to thank you so much for this great presentation. And I think the timing of this is really important, as you know, the PCPCC is going to be working with many partners around the country as we start to really work with practices in transforming them through the new TCPI. But I think this also is very relevant to all of those practices, as you pointed out, who've already started to go down this path of patient-centered medical home. And we know that practices do this in lots of different ways. And one of the things that we've been talking about is how sometimes there's this piece missing that talks about and brings up the issue of clinician satisfaction, or by one of our leaders in this area, Chris Sinski, who's a physician we're giving an award to in November, talks about and coined the joy of practice. Many organizations are even saying, you know, as it relates to the triple aim, it really should be the quadruple aim, because for all the importance that we put around improving care for patients, we also have to support and improve the lives and the professionalism of those clinicians, as you pointed out so well, and how the Plantree model addresses that. What were some of the kind of ahas that some of the health systems that you've worked with have kind of voiced to you? I love some of the quotes put up, but you know, I think when we first initially go to practices and we talk about being patient-centered, you know, their first reaction is, well, we're already patient-centered. Of course we're patient-centered. What were some of the things that, as you work with these groups and these individuals, that they start to kind of realize, like, oh, you mean something a little bit different or a little bit more? What were some of those ahas?
Lately, I'll share with you some of the ahas that I've been hearing, and a lot of them have to do with this concept of really partnering in a much more meaningful and impactful way with patients and family members on improvement activities, and bringing patients into the fold as our partners in really charting the course to a more patient-centered future. And I know that that can seem really scary and daunting at first, to bring patients in and sort of sort of breaks the rules a little bit to work shoulder to shoulder with patients and acknowledge that we don't know everything and we're struggling in certain areas. That we all bring sort of these different brands of expertise to the table, but time and time again, this is proven true in my work with organizations, that when they take that step and they start to invite patients and family members to be members of committees or parts of task forces or involved in improvement events or on a patient and family advisory or partnership council, they have these aha moments of, oh, the conversation has changed, because now we're no longer basing this conversation on assumptions of the patient experience. We actually have patients who are able to validate that we're heading in the right direction, help us to steer differently if we're not heading in the right direction, and it eliminates the need to come up with a solution and then test it out and then get patient feedback on it, because if you're developing that solution with patients and family members, it's going to accelerate that implementation phase, because you're already sort of doing that testing and vetting of patients as part of the development process. So I've worked with many, many, many skeptics of this concept who, once they start doing it, recognize that it is really, really a game changer and can be so instrumental in really having what matters most to patients become the priority and acted upon in a way that makes a real and discernible and measurable difference for patients.
Yeah, I couldn't agree more. I had the same experience when I was working with practices when we would introduce patients and family caregivers onto the quality improvement team. You know, even less than a year later, they would say, far and away, the most impactful thing that they did as part of their transformation into becoming a patient-centered medical home was bringing those patients and family caregivers on as partners. And I think that also lent to their ability to realize how important and valuable what they're trying to do is to their patients. Sometimes you get so bogged down in the day-to-day that you really forget, and it's very affirming, you know, to the clinicians who work with these patients. And I think you're right. It's something that they hadn't thought of before, and it can be a little bit intimidating and scary because it's so different from anything they've ever seen before, but the value at the end of the day far exceeds any of the struggles that they might have feared or had to overcome in the initial stages.
Absolutely.
Yeah. Hey, Marcy, I think you had a question that you wanted to pose to Sarah as we're kind of rethinking about the way we transform practices with partnership with patients.
Thanks, Amy. I do. Sarah, thank you so much for this presentation. We talk a lot about the fact that the PCMH, patient-centered medical home, isn't sufficiently patient-centered in far too many places. Sometimes we're still leaving the P out of the patient-centered medical home. And I think there's many reasons for that. Obviously, we're changing the culture of healthcare delivery, and culture change is slow. But one of the reasons is because I think policymakers and payers are very focused on the results for both utilization changes as well as cost savings when we talk about the PCMH model. Sometimes we forget that the point, like Amy's saying, is focusing on the patients, and we miss the forest through the trees. But I have no doubt that if I were a policymaker sitting here, I would ask the question, which is, do you know about the return on investment, and what is the data telling you? Certainly, making these changes is a qualitative decision that improves care. Does it also improve the business of healthcare delivery?
So yes, I'm sure you're not surprised to know, Marcy, that we get this question a lot. Obviously, this is, I mean, that's knowing sort of the value equation is really important. And so we do look at a number of different measures in order to demonstrate that return on investment. Now, in our value-based purchasing world, specifically in the hospital environment, of course, improvements in the patient experience are now built into the reimbursement equation. So as the model continues to drive improvement on patient satisfaction, specifically performance on the CAP survey, that does impact in a positive way the bottom line for hospitals that are using this framework. But I also don't want to minimize the importance of the staff side and the improvements in staff satisfaction, because when you think about not only staff satisfaction, but your ability to retain good staff, and not only the costs for recruitment and hiring new staff, but there's also the continuity factor. And we know from talking to patients that the relationships at the heart of healthcare are what truly do drive quality. And so being able to retain good quality staff who are able to do the kind of work that they went into healthcare to do in the first place, not only is important from a return on investment perspective, but that's ultimately what's going to enable you to deliver the kind of care that meets patients' priorities, which are, again, connection and feeling like they have, that they're known by their caregivers, that their patient preferences are understood and are accommodated, that they feel heard and listened to. But also we look at the data of our sites that have achieved designation and see that their quality scores are higher than their peers as well. And we know that that's because there is this emphasis on patient and family engagement and really taking full advantage and leveraging the patient and their support network as really the greatest source of continuity across a patient's full healthcare experience. So looking at the data, we know that their patient experience is higher, their staff satisfaction scores are higher, and then their quality scores as well.
Thank you, Sarah. So we've got several questions that have come in, and some of them are more specific to the kind of intricacies of the Plantree recognition process. So for instance, if a hospital is going through this and seeking designation through Plantree, does that hospital also get designation for their affiliated ambulatory care settings? Is that separate? Is that an intentional decision to draw those in? How does that process work?
So we work with the site to determine the scope of the award and the application. So you sort of have your choice. But if you decide to go as a system, so a hospital with the associated ambulatory settings, we design the assessment to make sure that we are evaluating the patient and staff experience at each of those locations. And that's because it's largely based on the patient experience, and patients don't experience healthcare, generally speaking, at a system level. They're experiencing it on the ground at each of the individual sites. And so if you were to make the choice to apply for the award as a hospital with the affiliated sites, we'd make sure that we were going on site, talking to patients at each of those individual sites, as well as doing focus groups with patients who had recently been discharged from the hospital as well, and talking to staff at each of those locations. Alternatively, you could make the choice to apply only as a hospital, and then the scope of the award would be only for the hospital, or alternatively, the third option would be the individual sites could apply on their own.
And once you get that designation, is it a one-time only process? Do you have continuing reevaluatory processes or other retrainings that happen over time? How does that work?
It's a 3-year designation. And that applies to bronze and silver level recognition as well, although you certainly have the option if you are recognized with bronze, you don't need to wait 3 years to apply for a higher level of recognition. Within the 3-year term, we do ask that there's a 1-year or an interim report just to demonstrate continued performance aligned with the levels required for designation. And then at the beginning of the 3rd year, you would submit your application for re-designation.
Fantastic. And, you know, in terms of the data that you presented and what you're hearing back from these designated institutions, are you going in and collecting that data yourselves through Plantree staff? Are you having them collect it through other means? You mentioned HCAP scores, and then bringing that back to you. Are you partnering with another analytics company to help obtain some of that data? How are you obtaining all of that information?
It's a combination of we will use publicly reported data. So you mentioned the HCAP, so we can go and get that from CMS, although we also invite sites to provide us with their most current internal data, since there is a data reporting lag and we want sites to have the benefit. We want to really understand the current state of the organization, and so sometimes what's publicly reported is not necessarily a reflection of the current state. And then we ask, as part of the application process, sites do need to be submitting to us staff satisfaction data, physician engagement data, culture of safety data, and then quality data as well.
Fantastic. There's a specific question regarding the data that you presented on the Sanford experience. You noticed that there was a slight decrease in staff experience ratings over the last 3 years. And was there any leveling off, or do you see that typically, that staff satisfaction reaches a certain peak at a certain point in time, or as part of when you come back in and refresh after 3 years, that there's another upsurge, or have you seen any trends related to that?
I wouldn't say any trends. I wouldn't go so far as to call it a trend. I mean, what I see on the Stanford data isn't alarming to me. I mean, we do expect that there will be some sort of ebbs and flows, and frankly, that's why it's a 3-year designation, because I don't think any of us thought that an organization would achieve that level of performance at one point in time, and that we could all take for granted that it would be maintained, because the sustainability piece and the maintenance piece that's the real challenge. And so we think it's really important that in order to sort of remain focused on these priorities, that this framework is a 3-year term, in order to go back in and sort of test some assumptions around what's been going on, because sometimes, and this is not with any ill intent, I think a lot of times we think these things are occurring because they occurred at one point in time, but unless you're going in and validating, and specifically talking to patients and family members to validate that they're occurring effectively, you can't really take it for granted. And so from a staff perspective as well, we all know this. You get into your day-to-day work, and it can be easy to become a little bit myopic and sort of lose a little bit of sight of that larger picture. And that's why we also really highly recommend that organizations do refresher type retreats, again, to continually reconnect staff. And Stanford is an example of an organization that has done that, and has also started a new initiative specifically focused on physicians and really around that joy of practice that you referenced earlier, because none of this can be taken for granted. And so finding ways to continually reconnect to why this is important and make it personal. And it's not about the designation framework. It's not about the gold seal. It's really about what we're able to provide for our patients and family members. The designation and the gold seal just provide a little bit of sort of a blueprint for going about it.
Right, exactly. Yeah, we certainly see that with all kinds of quality improvement initiatives. If it doesn't become part of the core mission and overall day-to-day structure, and that you're constantly reevaluating and measuring and processing where you're at in that on a regular basis, then it can easily start to slip away, and then you need to reconvene and rethink about how to infuse that back into your practice again. We certainly, I think that's a struggle that lots of practices face. And then when there's major changes in the organization, sometimes those things can start to fall away and lose some of the intent that they originally had. So lots of challenges in that. And as we're kind of talking about maybe some of those challenges, what have you seen, or some organizations have maybe said to you, are there any particular barriers to getting this recognition? Or what are some of the things that organizations really do first and foremost have to have in place in order to go down this path with Plantree?
Well, I think first and foremost, there really does need to be a strong leadership commitment. And I referenced this earlier in talking about leadership engagement. I mean, for an organization to find success in this and to make it really, to hardwire it to the extent that we're talking about, it needs to have the support of every level of the organization so that barriers can be overcome, and somebody with the authority who's able to say, yeah, this is going to be the way we're moving forward, and then certainly role models that to be the case. I think another area worth touching on is the measurement piece and the data piece, because I think one thing that we've continually struggled with is we do have criteria related to performance on staff experience and patient experience, specifically, as I mentioned, HCAHPS. But if this is perceived as just a recognition based on patient satisfaction scores, that's far too narrow a view, and the scores themselves can end up really compromising the culture that you're looking to cultivate in terms of really being supportive of staff and helping staff to provide the kind of care that they want to provide. And so we recently introduced on the bronze and silver level of recognition a different approach for recognizing organizations around measurements that really focuses on their ability to use data to drive change versus their performance against specific industry benchmarks, because that's where we think, I mean, that's the real competency you want to build here, is how do we use this data in a meaningful way, connect it to the voices of our patients and family members, and then act on it. And I think that's what takes it out of the realm of being sort of beaten over the head with these numbers to using this data as a real catalyst for bringing about the kind of change you're looking to achieve.
Yeah, my favorite quote that you put up was that this not only made us better professionals, but better citizens. I think as we're striving to find better ways to engage healthcare teams and work in partnership with patients and families, I mean, that really is the foundation of all of this. What do we want to do to not only be better professionals, but better people in this whole realm of trying to help each other obtain optimal health and live the lives we want to live in our communities. So Sarah, we're out of time. I knew this would happen. I apologize to those who submitted questions that we weren't able to get to. I promise I will share those with Sarah and we'll get an answer back to you. But again, thank you so much, Sarah. I think this is just critically important, especially at this time as we're really working to change the way we're delivering care in partnership with patients. I'm excited to say Plantree is a partner with us in our new TCPI SAN Grant Award, so we look forward to working with you much more closely as we're really working to advance the way we provide this model of patient-centered care moving forward. So thanks again to you. This will be recorded. This has been recorded and will be available up on our website tomorrow. So thank you, everyone. Bye-bye.
Thanks. Bye-bye.